great pleasure. Okay, now we're recording. I'll start again. It's my great pleasure to introduce Professor George Davey Smith. So George wanted me to have a very, very brief introduction, so we had lots of time for discussion, which I really appreciate in a very truly British way, just to understate things. But fortunately for me, his assistant sent a little bit of additional information. So George Davey Smith was a member of a band or a noise terrorism outfit called Scum Auxiliary back in the day. And I think the early 80s, but artistic and commercial success eluded them apparently. So he's had to earn his living working as an epidemiologist. So music's loss has very much been science's gain. And George is currently the director of the Integrative Epidemiology Unit at the University of Bristol, which is a place I know very, very well. So I'm delighted there's that connection, George. And George is going to talk to us about the fundamental principles of Mendelian randomization, and then help lead a discussion as we think to the future of the genetics of IBD, where we should be taking this and so on. So George, I'm delighted that you've taken time to share your expertise with us. What I suggest is that you give your talk and take questions afterwards, because there'll be plenty of time for discussion and we can go back to the slides and whatever. Is that okay with you?
Yeah. I was planning for 30 minutes and then time for discussion.
Perfect. That would be perfect. Thank you, George. It's all yours.
Great. Thanks. Thanks very much, and thanks for the invite. So yeah. So in this introduction, I'm going to say what Mendelian is, how it was introduced, and then talk about the fundamental assumptions and how it can be implemented. And then I'll just touch on the range of sensitivity analyses to test robustness, and then finish on suggesting that Mendelian randomization fits with a sort of triangulation of evidence framework, with evidence coming from other sources. What I see Mendelian randomization as being is using the special properties of germline genetic variants to help to strengthen evidence regarding the causal effects of exposures, modifiable exposures, on outcomes using observational data. And of course, the special properties of germline genetic variants are that they're assigned at conception and they don't change once assigned. The germline variants don't change. And the other properties of them relate to Mendel's laws and how they are distributed independently of the factors that would confound conventional observational studies. And Shari, Brem and I wrote a paper about 20 years ago, which was a sort of extended exposition of this principle of Mendelian randomization. And in that, we said that one sees true randomization in parent offspring studies. If you have siblings and you're looking between siblings, then the differences in the siblings and the germline genetic variants is essentially randomized according to Mendel's laws. So Mendel's first law of segregation suggests that the two alleles for either parent just segregate, and it's random which one would go to into the gamete and then into the zygote, and that segregation through to conception will not relate to environmental external factors. So that would be the first law, and the second law being independent assortment, that the genetic variants at any particular locus are independent of those at any other locus except ones that they're in linkage disequilibrium with, which will be a very small proportion. obviously, of the genome. So if you're within a family setting, looking between siblings, the variance shouldn't relate to confounding factors. And obviously there'll be no reverse causation, which occurs in observational epidemiological studies. So that in the between sibling setting, there really is an analogy to a randomized controlled trial. Though of course the randomization is to a genetic variant which influences a phenotype, and that therefore that difference in the phenotype that's related to the genetic variant, that element of the phenotype should be independent of confounding factors. There shouldn't be reverse cause, etc. Of course, 20 years ago, there were not large-scale population studies with families that would allow you to do this within families. And that at the population level, if you took population stratification into account through adjusting for principal components from GWAS data, although we were writing this pre-GWAS, if you could take population stratification into account, then there would be a sort of approximate randomization. The genetic variants will not in general relate to all the confounders that observational epidemiology finds difficult to deal with. The socioeconomic, physiological, behavioral sort of factors that confound observational epidemiological studies. But now, in 20 years on, there are now large-scale family studies, and it is now possible to do the between sibling analysis, which is a very powerful sensitivity analysis within Mendelian randomization. So in conventional observational epidemiology, you measure your exposure, body mass index, C-reactive protein, LDL cholesterol, whatever. And then you observe how that relates to the outcome, usually prospectively, ideally prospectively. I mean, the problem, of course, is that the early stages of the disease process that you're looking at might affect the exposure. And there are, for example, if people are developing cancer, then that might lead to lower weight before the cancer is diagnosed. And so the disease process can actually influence the exposure, but that would lead to an apparent prospective association between the exposure and your outcome, death from cancer. And of course, there's a huge number of potential confounders, as I say, socioeconomic, behavioral, physiological, that could generate a non-causal association. So it's impossible to exclude that in observational studies. And of course, we have lots of examples from, where observational studies suggested that vitamin E supplementation reduced coronary heart disease risk by 40%, and people started taking vitamin E supplementation when those studies appeared. But randomized trials of vitamin C supplementation for up to a decade showed no evidence of any benefit. So you can get highly misleading findings from observational studies. But if you have a genetic variant that relates to the exposure, for example, a variant in the FTO gene that relates to body mass index, then that will not be influenced by reverse causation. Obviously, the disease developing will not influence the genetic variant you received, nor will it be confounded by the factors that would confound a conventional observational study. So that allows you to have some estimate of the causal effect of the exposure on the outcome by just utilizing that component of the exposure which is influenced by the genetic variant as your exposure, essentially, by relating the genetic variant to the outcome. Now, the fundamental assumption here, if you're trying to use this approach to give you evidence about whether modifying an exposure will will influence the outcome, is that the way the genetic variant influencing the exposure will have the same downstream effect on the disease if that exposure is influenced by the sorts of external factors that one could change the exposure by. If a genetic variant relates to LDL cholesterol, and that suggests, and also to coronary heart disease, and that suggests strengthening evidence that LDL cholesterol influences coronary heart disease risk, that the modification of LDL cholesterol by genetic variants has the same downstream effect as if you modify LDL cholesterol by diet or pharmaceutical agents, for example. So that's the assumption of gene environment equivalence. Now, there are examples within genetics where there's rather clear equivalence. So, for example, the condition pellagra, which is caused by niacin deficiency, the phenotype in pellagra is closely mimicked by a Mendelian condition called Hartnup disease, which results in the same symptoms. And within Hartnup disease is caused by genetic disruption, which leads to poor absorption of amino acids, including tryptophan, which are converted to niacin. And that disruption leads to a phenotype which is similar to pellagra. And in sort of developmental genetics and elsewhere, there is this assumption that that environmental effects can be mimicked by genetic variation. And Mary Jane West Eberhardt refers to this as gene environment equivalence and gene environment interchangeability in this developmental genetics sphere. And in a well-known paper by Zuckerkandl and Ville, they said that no doubt all environmental effects can be mimicked by one or several variants, as I said. I mean, I think that within limits, one can see that will be the case. I think it's the case for endogenous processes and disease-related processes. I can't myself think of a genetic variant that would mimic being hit by a truck, for example, but for this, probably the sorts of exposures which in disease epidemiology we're usually interested in, and the outcomes we're interested in, there's reasonable basis for it. So, as I say, the Mendelian randomization approach has been referred to as an instrumental variable approach because the genetic variants are utilized in this setting as instrumental variables are used, as they have been in econometrics and elsewhere, to try and strengthen causal inference. So the genetic variant is the instrumental variable in this context. The gene environment equivalence is the assumption that as I say, that the modifiable exposure, say LDL cholesterol, is influenced by diet or cholesterol-lowering medication, has the same downstream effect. So this is a key assumption. Now, I mean, in the situation with LDL cholesterol, this is very reasonable because many of the drugs which have been tested in long-term trials, randomized controlled trials, you have genetic proxies for those drugs in the cis genetic variants in the genes that the drugs target. So, for example, in HMG-CoA reductase, and they mimic statins, in PCSK9, mimic PCSK9 inhibitors, in NPC1L1, which relates to cholesterol absorption across the gut, might be taken to mimic dietary cholesterol, that there's ezetimibe works through that gene, etc. And in fact, if you look at the effect of genetic variants in the genes which mimic the drugs I've mentioned, but also in CETP, which is targeted by CETP inhibitors, and their effect on non-HDL cholesterol level, or ApoB cholesterol level and ApoB carrying particles, then in this situation there have been trials and, as I say, the Mendelian randomization studies. And if you look for the same degree of difference in the LDL cholesterol produced in the drug trials, and you look at how the genetic mimics what they predict, the effect they predict for effect of LDL cholesterol and coronary heart disease, you see that it scales these things scale very nicely across the degree to which cholesterol is lowered. The drug trials produce about 40% of the effect predicted by the genetic studies. But this is entirely as anticipated from a condition like atherosclerosis, which accumulates from childhood, adolescence on. And of course, the genetic variants are related to differences in cholesterol level right the way across life. And in the trials, you're only lowering cholesterol for, say, 5 or 6 years. And so this, you obviously would not expect to get a complete reversal of a process which has been generated over long term. So a really key difference is that the genetic variant effects relate to the differences that the genetic variants produce over life. And for many exposures, the genetic variants have been assessed in relation to LDL cholesterol level in childhood, and you see that they relate to similar sort of proportional differences then as they do later in life. But that's a really key concept, is that the genetic variants relate to the difference produced from conception onwards. So here's a brief schematic on an instrumental variables thinking. So you have your sort of exposure and your outcome, exposure of interest and outcome, and you have your confounders. And then you take your genetic variant that reliably relates to the exposure, that is the instrument for the exposure. And firstly, the genetic variant must relate to the exposure, which is the relevance assumption. The second assumption is that there is no confounding factors that influence the genetic variant and influence the outcome, no confounding of the outcome instrument association. Now, in genetics, the only real confounders that could exist are population stratification, population differences that might relate to different distribution of the genetic variants and different distribution of the outcome, or dynastic effects. Dynastic effects are those where the genetic variants in the parents may create differences in the environment which the child grows up in. Now, for a lot of biological processes, straightforward biological processes, that's not really very plausible. But for, say, Mendelian randomization studies have been done of the effects of education on a lot of outcomes. And in the case of education, of course, the parents' genetic variants that relate to educational attainment may relate to the numbers of books in the home, parenting style, etc., which may that themselves influence the outcome. So there you would have something which influences the distribution of the variance and the outcome. Of course, if you do it within siblings, between sibling studies, if you do a study between siblings, they've got the same parents, so that confounding doesn't exist. So that's one of the very powerful things for the between sibling studies. And the third and the most challenging assumption is that the genetic variant doesn't relate to the outcome except through the exposure. So the entire effect of the genetic variant on the outcome is mediated through the exposure. That's called, in econometrics, that's called the exclusion restriction assumption. In genetics, the main when that is transgressed is through horizontal pleiotropy. The genetic variant has an effect on the outcome through a completely independent pathway. The genetic variant is influencing more than one exposure that influences the outcome. So in the case of horizontal pleiotropy, obviously a genetic variant can't influence an outcome without going through some biological pathway. So the horizontal pleiotropy will be the genetic variant is influencing the outcome through another pathway that is independent of how it influences the exposure. That's a problem for Mendelian randomization. If you have a vertical pleiotropy where a genetic variant influences one factor that then influences your exposure, which influences your outcome, then that in itself doesn't violate the assumptions. In fact, vertical pleiotropy is the essence of Mendelian randomization. In fact, you have a genetic variant that relates to body mass index, and that in turn relates to coronary heart disease, that is a vertically pleiotropic pathway, and you're using that to say that body mass index influences coronary heart disease. Vertical pleiotropy is only a problem if you don't realize that there is this, the genetic variant is working through this pathway, and if the most proximal phenotype to the genetic variant, if you don't know about that one, and you consider that a genetic variant for body mass index is actually a genetic variant for CRP, and body mass index influences CRP, and the FTO variant related to body mass index is a genome-wide significant variant for CRP. If you didn't know that it was working through body mass index, you'd get the wrong answer because you might take it to be an instrument for CRP. So vertical pleiotropy can lead to misspecification of which is the primary phenotype, and that leads to wrong answers. And of course, if your genetic variant relates to a phenotype you don't know about, which influences both your exposure and your outcome, and that is called correlated pleiotropy, and is the most problematic case of all. So the threats to the validity of Mendelian randomization include population stratification, which I've mentioned, and where between sibling studies are of use, low power, canalization, which is where the genetic variant might influence something early on in development, which leads to later phenotypes not having the same influence on disease as they would without that compensatory process, for example, occurring. So that's a developmental issue which may exist. But the major, as I say, the major issue is horizontal pleiotropy. Horizontal pleiotropy can be interrogated by using a large number of genetic variants that relate to the exposure and using a range of variants, multiple numbers of instruments, and seeing whether the instruments predict the same causal effect of the exposure on the outcome. Because whilst for any single particular genetic variant in any particular location, it may be plausible, or is plausible, that there may be horizontal pleiotropy, which, for example, could perfectly balances the effect of the variant on cholesterol, and so you don't see an effect of the variant on coronary heart disease. That could exist, or that exaggerates an association. But it's less and less plausible when you have many genetic variants that are on different chromosomes, working through different genes, obviously, where you have many different variants which generate the same effect estimate. That situation would only be generated by the sort of correlated pleiotropy if, for all of these variants, they influence a phenotype which is higher up the causal chain, and you don't know about it. But multiple genetic variants that influence your exposure, if you get the similar answer with all of those, that increases confidence. And heterogeneity test, so in this graph you can see there's very little heterogeneity because they lie on a pretty perfect slope. The heterogeneity statistic between the instrument is the first way of interrogating that. Now there's quite a large number of sensitivity analyses which allow relaxation of some of the assumptions. One of the first ones introduced was called MR-EGR, because it utilized the EGR regression, which is used for testing for small study bias in meta-analyses, and uses similar principles. Here, if you imagine there's a set of pleiotropic variants which are generating incorrect estimates, which are the 3 dots above the line on the left-hand graph. If you force your regression through the intercept, then you will have a biased causal estimate. But if you let the intercept float, so you don't fix the intercept, and carry out the regression, you actually would obtain a valid causal estimate. So this can produce valid causal estimates even when some of the variants are pleiotropic, horizontally pleiotropic, with an assumption which is weaker, a weaker assumption than no pleiotropy, which is that the extent to which the genetic variant relates to the exposure doesn't correlate with the extent, the horizontally pleiotropic effect, which is obviously violated by correlated pleiotropy. So this test is, this approach allows estimation, which is robust to, but requires other assumptions. But there's a whole host of sensitivity analyses, and more have been added in the last few months that allow relaxation of assumptions in different ways and can be applied. So when you're interpreting the IV estimates, you need all the IV assumptions that I've mentioned. You've got to remember that MR may indicate a lifetime exposure effect. It may relate to an exposure acting only during a critical period. So say, for example, vitamin D levels during puberty or during the time that you become infected with Epstein-Barr virus, your vitamin D levels influence whether you develop, whether the EBV infection leads to multiple sclerosis. But it's, it's exposure at a very critical time of a particular time of life. Your Mendelian randomization will just tell you that vitamin D, genetic variants related to vitamin D across life, protect against, are related to lower risk of multiple sclerosis. You wouldn't know that that was only occurring during the critical period. And if you started giving people vitamin D after they'd developed the disease or after the exposure had occurred, indeed, it would not be beneficial. So knowing about the disease biology is powerful. So the exposure, there may be a critical period exposure effect. It may be related to an upstream phenotype, which I've mentioned earlier. Say your genetic variant relates to a different level of enzyme activity, which relates to different levels of lots of fatty acids. You can't take that genetic variant to be an instrument for the fatty acid, for any particular one of the fatty acids. You're estimating an overall population effect, and it may only be interpretable in terms of liability to the exposure, not to the exposure itself. So by this, I mean, if you're trying to carry out studies, as people have done, to say, does type 2 diabetes influence coronary heart disease? And if you're implementing Mendelian randomization, as these days it is most often implemented, which is in a 2-sample design where you obtain the evidence on the genetic variant exposure association from a large GWAS of the exposure, and the genetic variant outcome association from a large case control GWAS of the outcome. If you're doing that, then of course you can't know whether people that you're in the study that you're instrumenting actually go on to develop the exposure, whether they actually go on to develop type 2 diabetes. So what you're testing in that situation is that the genetic liability to type 2 diabetes influences coronary heart disease risk, not that the actual event of type 2 diabetes is influencing coronary heart disease. To do that, you would need a very complex single sample design when you actually had data, when you actually knew when disease developed, type 2 diabetes developed, etc. And no such studies have been done, as they would be very complex and require very detailed prospective data with dated events. So if you're using genetic instruments for disease, for example, or for a qualitative state, then the interpretation is to the liability to that state. And crucially, these studies generally relate to the disease occurrence, not the outcome of disease. So what one might want really is to use Mendelian randomization to know whether a therapeutic is likely to work. So if you do MR for looking at in multiple sclerosis, you would want to say, would we get a treatment for multiple sclerosis? But most of the data that are available are generated by, for example, case control studies of your outcome. So what you're actually looking at is factors that relate to the occurrence of the disease, not the progression of the disease once you've developed it. And I mean, to take an obvious example is in the case of lung cancer, the strongest genome-wide significant hit for lung cancer is in a gene CHRNA5, which relates to how heavily people smoke. So indeed, you show the genetic variant related to heavier smoking does indeed relate to lung cancer. But once you've developed lung cancer, stopping smoking isn't any use. So it's not telling you anything useful therapeutically. It's telling you things which relate to the occurrence of disease and prevention of the disease. And there aren't really many studies that have actually got genetic data on disease progression. And in many conditions, in particular, cancers, diseases generated by immune processes, it's rather likely that the factors which trigger the disease are not going to be the same as those that relate to disease progression once you've developed the disease. So what are required are genetic studies of disease progression. So why generate IV estimates? Well, all those sensitivity analyses I mentioned, they are based upon the IV estimates. So you need to generate the IV estimates for the sensitivity analyses. And the comparison of the IV estimates and what is observed in trials can help inform about the relative immediacy of treatment effects, as I showed with respect to LDL cholesterol and coronary heart disease. In the case of BMI and type 2 diabetes, for example, the suggestion is that the effect is of greater immediacy, i.e. More of the lifetime effect is recovered quickly through losing weight. So that can be powerful. And in some cases, for example, if you're using genetic variants related to heaviness of smoking during pregnancy in women to look at whether smoking influences birth weight and where the exposures must be basically acting during pregnancy or possibly preconceptually, you have a pretty well-defined period of exposure. So you can define the exposure period. I think that Mendelian randomization is a powerful method that would contribute to putting evidence together from different sources to get the best evidence on a causal effect. So MR studies combined with randomized trials. The randomized trials may sometimes be of sort of things influencing the exposure, but then your MR was telling you about the exposure outcome. But you can patch together evidence from these different approaches, from natural experiments, from study designs which use negative and positive controls to help strengthen causal inference, cross-context comparisons, etc. There's quite a toolkit of study designs which can provide better causal inference. So it's combining data from studies. Every study design can be biased. Even randomized trials can be biased in particular ways. But the factors that would bias a Mendelian randomization study, such as horizontal plerotropy, would obviously have no influence on a randomized control trial or on a negative control study. So utilizing methods, all of which individually can be biased, but where those biases would not correlate across study types, would be unrelated across study types, through a sort of triangulation of evidence approach is the most powerful. So triangulation of evidence with genetic designs and non-genetic designs, I think, is powerful. I've just finished with one or two, I think, examples of Mendelian randomization in inflammatory bowel disease work. Vitamin B has been said to prevent nearly everything and be good for nearly everything, which always, including COVID treatment, of course, which always makes one concerned. and Mendelian randomization studies suggest that the vitamin D is not having a causal effect on the risk of inflammatory bowel disease, despite some epidemiological studies suggesting this. This is a study on this is a pharmaceutical target MR study with interleukin 18 as a potential drug target. MR studies have been done which suggest that the observational association that smoking is related to lower risk of ulcerative colitis onset isn't seen in the Mendelian randomization design. So there have been quite a lot of MR studies of inflammatory bowel disease, and that's my introduction over.
Great. Thanks very much, George. A tour de force. Really, really outstanding. Appreciate certainly finishing up with some reference to what people have started to determine, that the vitamin D cult, and also talk about IBD. So I wanted to open it up to questions. I think you had questions, comments, and criticisms at the end there.
Yeah.
All of the above.
Yeah.
And if people want to type in questions into the chat, I'm happy then just to get people to unmute and so on. So while people do that, George, you just touched on it briefly there. I had one question sort of lined up. Maybe you can expand upon this a little bit. This sort of enduring mystery about smoking and IBD. So we have these very closely related genetic conditions, ulcerative colitis and Crohn's disease. And smoking exacerbates Crohn's disease, increases your risk of it, you're more likely to get severe disease, non-response to therapy. But your biggest environmental risk, arguably, for developing ulcerative colitis is being a smoker and giving up smoking and developing ulcerative colitis in the 6 months. How can you help us solve that problem?
Yeah, so that's an interesting example. Yeah, so when you just sort of take cases of ulcerative colitis, and this is the problem. I think this is a very good question, and illustrates the sort of data problem that most of the studies that are doing MR on inflammatory bowel disease use the big GWAS consortium of Crohn's disease and ulcerative colitis, which the data that they have is essentially, you've got people who are cases, and they might have been cases for a long time before they're recruited into the study, so they have to have survived to get into the study. Then some of them may be incident cases, but what you're looking at is basically factors that lead to developing the disease. The MR studies, I was oversimplifying by saying that they didn't they didn't suggest that overall smoking was protective, that ever being a smoker was protective. But to look at giving up smoking and then sort of the period after, then what you would need, as I say, would be a sort of data set where you actually have prospective data and know when people took up and gave up smoking, and combining that with genetic variants that would be related to heavier smoking over the period before giving up, for example, combining those data, it would in principle be possible to strengthen inference. But the data on smoking do indeed suggest that there is something there is, because it's a sort of odd pattern of findings without a simple explanation, the sort of the sharp null of, you can give those sort of sharp null about whether ever smoking, being an ever smoker protects one against ulcerative colitis, and that's is no, but it could be a complex exposure pattern that you mentioned. I mean, the thing which happens, of course, when people give up smoking, is they put on weight, and I think one of the most powerful examples actually of Mendelian randomization in observational data is looking at this issue, which is just, it's sort of impossible to disentangle with just observational data, or it has been impossible to disentangle, which is the effect of some on weight, on body mass index, fat distribution, etc. Some observational data did suggest that smoking led to weight loss, but this was extremely, or at least weight maintenance or lower weight gain, which of course is extremely unpopular for obvious reasons, extremely unpopular message. That could be tested by using the ChRNA5 variant, which relates to how heavily people smoke, but doesn't relate or relates very weakly to whether they smoke at all. So basically, it doesn't influence you having your first few cigarettes, but if you're in the group, or the group which carries the variant related to higher risk of lung cancer, for example, if you're in that group, then once you've started smoking, you will smoke more over your smoking career. You will smoke more to a greater extent than is seen if you just look at the number of cigarettes per day that people smoke. We looked at cotinine levels, for example, and the people who carried the variant related to heavier smoking had higher levels of cotinine than expected by just the one cigarette a day that it relates to, which might reflect, I haven't got strong data to support this, but might reflect the fact that people are actually smoking each cigarette, they're smoking more heavily, they're smoking it further down the butt, or taking more inhalations, for example. They certainly get a greater level of cotinine than expected, just on the basis of the one cigarette a day. I mean, one cigarette a day, of course, is bad and would lead to an expectation of greater lung cancer. But the greater lung cancer that is seen is larger than the one cigarette a day, but it's perfectly matches, closely matches the expectation from the level of cotinine, and that taken as a marker of actual inhalation and smoking style, and how much bad stuff you get out the cigarettes. So on the one hand, so you answer this question that yes, smoking does indeed lower BMI, but then you can also show that there's a bidirectional effect, and that that having a higher genetic liability to body mass index leads to greater smoking, and that is a bigger effect in women than men, which is just, I mean, people are smart, and people have experientially, people know that smoking is a way of controlling appetite and maintaining body weight. And so if you have a tendency to have higher body weight, you're more likely to continue smoking, as presumably as a mechanism to try and maintain your body mass, your body weight. So that's an incredibly complex, that's a very complicated pathway, which just it was not really possible to disentangle that using just observational data.
Great, thank you. The questions are piling in, so I'm going to ask some people just to unmute and give their questions. So Shantanu Bafna, do you want to ask your question?
I wanted to ask whether the strength of the associations are related to number of SNPs that we use in the MR analysis. Like for example, when we use two different methods to select independent SNPs, does it affect the strength?
Yeah, so again, that the SNP selection is a complicated issue. I mean, initially, when people started doing these studies, you were lucky to have one SNP related to the exposure, and then or a handful. The advantage of having multiple SNPs is that you explain more of the variance in the exposure, which means you have more statistical power and therefore greater precision of your effect estimation. So that's an unequivocal win of more SNPs. The second advantage of multiple SNPs is that the sensitivity analyses, which are generally, not all of the sensitivity analyses are based on multiple SNPs. Within sibling doesn't require that. Interaction analysis, which I haven't talked about, doesn't require that. But most of the sensitivity analyses depend on multiple SNPs. So you can do sensitivity analyses, which is powerful. The downside of more SNPs is that as you include more SNPs, you're obviously more likely to be including SNPs that are pleiotropic SNPs, horizontally pleiotropic SNPs. But also, and I think crucially, you're more likely to be including SNPs because, of course, you're including SNPs with lower and lower effect sizes. As you know, when you get larger and larger GWASs, we get more and more SNPs, and you include SNPs with smaller and smaller effect sizes. And it's just very obvious that some of those SNPs are SNPs for upstream phenotypes. So for vitamin D, for example, SNPs related to body mass index, FTO, and SNPs that relate to educational attainment, both relate, some of them, not all of them, obviously, power with all of them, but some of them are the genome-wide significant SNPs for vitamin D. So if you just we include everything that's genome-wide significant, you'd be including SNPs that are giving you the wrong answer, because for many outcomes, because if they work through body mass index, then of course the ones that relate to higher body mass index relate to lower vitamin D, but the body mass index influences coronary heart disease, and you would misinterpret that as being that vitamin D protects. The same is the case with CRP, where SNPs related to body mass index, to smoking, etc., and relate to remnant cholesterol, VLDL triglycerides. Those influence CRP. Those processes influence CRP and also influence downstream outcomes. So the disadvantage of including multiple SNPs is you're more likely to start including SNPs which are in this terrible, or in the worst category, which is the category of correlated pleiotropy. Now with FTO, with the examples I give, we know about the processes, but it'll it'll also be the case that some of these variants will relate to upstream phenotypes that you don't know about. So the problem with just including all the SNPs is that you're more likely to include those, and that especially for correlated pleiotropy, the sensitivity analyses are limited and are not, aren't so strong. So often if you're doing Mendelian randomization of a protein, it would be where there are cis variants, which have a very strong biological prior, the variants in the CRP promoter region, then they're most likely to be having their effect through CRP and not of upstream phenotypes. So for Mendelian randomization of proteins, often just cis SNPs will be used, or at the very least will be used as a sensitivity, as a secondary analysis, or maybe the primary analysis. And there's examples of where when you move from the cis SNPs to large numbers of SNPs, the results change, and the cisNIP ones are generally more believable. A powerful analytical method, although it's only available in certain circumstances, is where the SNPs, that the SNPs are having a differential effect in different groups because of behavioral factors, for example. So an interaction example would be, you look at the CRNA5, the ChRNA5 variant that relates to heaviness of smoking, but doesn't relate to smoking, whether you ever smoke. Then in never smokers, that doesn't relate to lung cancer. Whereas in people who've ever smoked, it relates to lower lung function, high risk of lung cancer, and lots of other things, including premature aging and skin wrinkling. So facial, in biobank, facial aging is related to CRNA5 if you're a smoker, but not if you've never been a smoker. So, in East Asian populations, I think some of the most, probably some of the more influential MR findings in public health have come from studies of alcohol, where, of course, the discourse for many years has been that alcohol protects against cardiovascular disease, for example. So the very bad news is that the Mendelian randomization using an ALDH2 variant, which strongly relates to alcohol consumption in East Asian populations because it makes alcohol drinking unpleasant. Sadly, the Mendelian randomization suggests there's no protection against cardiovascular disease. There's an adverse effect of alcohol at all levels on overall cardiovascular disease, because a major effect on hemorrhagic and even ischemic stroke, probably neutral effect on coronary heart disease, but overall harmful, and that much of that effect is through blood pressure. So I take an ACE inhibitor, but carry on drinking. But the powerful interaction there is that in women in those areas, historically the drinking rates have been very low, and in women the ALDH2 variant doesn't relate to cardiovascular disease at all, but in men there's adverse consequences of carrying the variant related to drinking more. So I think with the CRNA5, I'm going to think of Dermot's question about how one could design a study that could say about, I'm not going to answer it now. I'll think about it in the bath later, and because that is an interesting example of where maybe you could do something interaction-wise.
George, I think we got just a couple of minutes left. I want to give one last chance for questions. So, Dalen Lee, do you want to just unmute yourself and ask your questions?
Thanks, Dr. Smith, for the great question, for the great speech. I have actually two questions. One is, can we say that Mendelian randomization from a conceptual work, it is completely shielded from the bias of reverse causality?
Okay, I'll answer that one. I'll answer that one first, and then I'll answer your second one, because I've got a very bad memory. That's a really good question. Now, the Mendelian randomization is protected from reverse causality in terms of, you don't change the instrument. MR may appear to be influenced by reverse causality through misspecifying the primary phenotype. So, what I mean by that is, if you have a genetic variant that relates to developing atherosclerosis, and then having high rates of coronary heart disease, okay, genetic variants that do that will, of course, relate to things that atherosclerosis produces. And atherosclerosis is an inflammatory process. Atherosclerosis increases CRP, for example. So you could actually be taking genetic variants that relate to CRP, but through atherosclerosis, you could consider them to be genetic variants for CRP. Now that looks like reverse causality, but it's because you're misspecifying the primary phenotype that the genetic variants relate to. But yeah, but I think there's many examples that one can think of with different diseases where if you don't know the process that's working, that a variant relates to, a process that leads to the disease. If it relates to something else, then the genetic variant will of course relate to that factor, and it might be mistakenly taken to be an instrument for that factor. So that's a very good question, and it's a difficult as an issue to look at.
Thank you.
Your second question.
Is there a good way to deal with the correlated instrumental variables like SNPs in partial RLD?
So if you mean taking SNPs, for example, this more than one promoter region variant that relates to an exposure, then methods have been developed so that you don't exaggerate the strength of your instruments. But are you talking about are you talking about variants that are in LD with variants that influence some other pathway? If the variants are in LD with other variants that might influence the disease, an alternative pathway, then in practical terms, that is similar to horizontal pliometry. So the sensitivity analyses that have been developed for horizontal pliometry would take that into account.
Thank you very much.
Great. So we're at the top of the hour. I know there were some questions that we didn't get a chance to get to, but I think that was always going to be the case. But on behalf of the steering committee of the IBD Genetics Consortium, and in fact, on behalf of everyone, I think, on the call, George, thank you so much. Absolutely fantastic. A lot of food for thought for us. I think you're going to go away and think about things in the bath. I'm not gonna share that image with you of me thinking about things, but definitely food for thought for us as we go forwards as a consortium on big decisions we need to make about our future directions and so on. This has been incredibly helpful, certainly from a personal perspective and just seeing some of the feedback and so on. So we very, very much appreciate it.
I'd like to say with that, thanks for the invite. And the point I made repeatedly that what are needed are studies of inflammatory bowel disease progression. If people are developing studies of inflammatory bowel progression in the consortium, then this is a complicated issue to analyze with Mendelian randomization, because you get I gave a short talk and didn't go into it, but you get a problem with what is called collider bias, which means that the variants that relate to the disease onset if you're looking just at people who have got the disease, they become confounded with other genetic variants and other environmental factors. And one of the main pieces of work that the unit I'm in, the integrative epidemiology unit, we're working on are methods for dealing with this additional bias, can be very problematic bias, because as I was saying, I think one of the most exciting ways forward for Mendelian randomization would be doing studies of disease progression, which would talk directly to therapeutics. So if work's going on in that area, I'd be very happy to talk to people and discuss methods, etc.
Oh, that's great. Well, expect a flood of emails then. But again, thanks very much, and thanks for talking to us despite the effect of your cold on your voice, and congratulations for that standing up. Very much appreciate it.
Pleasure. Thanks.
Bye. Take care.
Goodbye.
Thanks again.
Thank you.
Bye.